Hello, everyone, and welcome to LGBTQ plus Health Grand Rounds. My name is Wei Chen. I use she, her pronouns, and I'm the program manager for Stanford Medicine's LGBTQ plus health program. For visual description, I'm an Asian woman with medium-length black hair wearing a blue turtleneck today, but I just thrifted if I do say so myself. And I'm thrilled to share the Zoom stage with our presenter this month, Dr. Mitchell R. Lunn. Mitchell R. Lunn, MD, MAS, FACP, FASN, he, him pronouns, is a physician scientist board certified in internal medicine, nephrology, and clinical informatics. He consults on hospitalized patients with renal diseases and electrolyte abnormalities at Stanford Hospital. Dr. Lunn's research focuses on sexual and gender minority health, addressing the disparities faced by these underrepresented populations. His research explores factors including influencing SGM health, including health disparities, societal expectations, experiences, provider education, and institutional climate toward SGM people. He co-directs the PRIDE study, a prospective longitudinal general health cohort study of over 31,000 SGM adults nationwide, and PRIDEnet, a participant-powered research network that engages SGM communities in the research process. Please note this session is being recorded and published on the Department of OBGYN's public YouTube channel. For your convenience, we want to highlight a few of Zoom's built-in accessibility features to ensure everyone can fully participate. Zoom offers live automatic captioning, which you can enable by clicking the Show Captions button in the Zoom toolbar at the bottom of your screen. And if you don't see this option, click the More menu with the three dots and select Show Captions from there. You can adjust the size and appearance of captions in your Zoom settings under the Accessibility menu. We encourage you to explore these tools and use what works best for you throughout today's session. And if we can help meet any additional access needs, please feel free to reach out to me via the chat at any time. Throughout the presentation, please feel free to add questions and comments directly to the chat because we'll leave some time at the end of the hour for Q&A. And with that, I'm delighted to hand us off to Dr. Lunn.
Thank you so much. Thank you, Wei Chen, and thank you so much to you and the organizers and the other organizers for having me here today. Hopefully, y'all can see my slides. It's really a delight to be here. Over the next half an hour or a little longer, I hope that we'll be able to share some of the highlights of research work that's been done in the field of LGBTQ health over the past year or so, as well as a little bit of my insight as to what I think we need going forward. So with that, let's get started. No real relevant conflicts of interest here other than funding from both federal and non-federal sources, including some institutional funding and then some consulting work that I've done in the past. And I usually start a lot of these presentations with a little bit about me. So first of all, as a visual description, I'm a white, middle-aged cisgender man with brown hair, brown facial hair, wearing a light blue button-down shirt today. I am a gay man, primarily of Scandinavian ancestry, who grew up in North Dakota. And clinically, as you heard, I'm an internist and a nephrologist, but my primary academic duty at Stanford is LGBTQ plus health research. One of the co-founders and co-directors of the PRIDE study, a longitudinal health study here at Stanford it looks at physical, mental, and social health of LGBTQ plus people. And I'm also one of the associate deans for research for the School of Medicine. And so as an academic administrator, I usually do share that the views that I share today may or may not represent the views of Stanford University, but are actually my own views. We have a limited time today, and in order to really have this, be with time for questions at the end, I wanted to share a little bit of just how I chose the 6 research papers that I'll go through today over the past year. And this was actually done by crowdsourcing recommendations from dozens of LGBTQ health researchers across the country, because I didn't want it to just be my thoughts about the most impactful presentations. And so hopefully, as we go through this, you'll see things that are affecting a variety of groups of people. Additionally, at the end, I will provide a QR code with a list of the 45 papers. We're only going to do 6 of them today, but the 45 papers that I received from folks across the country, so that folks can really go deeper if they wish into some of the some other impactful papers that have been published in approximately the last 12 months or so. So let's dive in. I put a lot of the stats just just so it's clear on the screen, even though I may not necessarily talk about them. So the numbers will be on the screen, the actual interpretation and other things will be things that I say going forward. So let's start with this first study. This is a study by Dr. Gibb and colleagues, and they examined the association between conversion practices, or sometimes so-called conversion therapy, on cardiovascular health. And this study included about 700, just over 700 participants from RADAR, which is a cohort study of young men who have sex with men, transgender women, and non-binary people based in the Chicago area. 72 of those participants reported either prior efforts to change their sexual orientation or their gender identity. So these get abbreviated as SOGICE, or sexual orientation and gender identity change efforts. And in addition to a standardized study obtained blood pressure, as well as blood-based inflammatory markers, the participants were also asked if they had a self-reported diagnosis of hypertension or high blood pressure. And in short, compared to those who did not experience any conversion practices, those who did were found to have both higher systolic and diastolic blood pressures, higher amounts of those inflammatory markers, and more self-reported hypertension and high blood pressure. And those who experienced sexual orientation or gender identity change efforts for more than 1 year saw even more pronounced effects. And so this was really one of the first studies that demonstrated that sexual orientation and gender identity change efforts are associated with cardiovascular implications in young people. And of course, this is oftentimes sexual orientation and gender identity change efforts that happened many years ago are still showing detrimental cardiovascular effects ongoing. And so this is a really great tie-in of basically a mental health activity of trying to change somebody's sexual orientation or gender identity and its impact on cardiovascular health. For the second study, we'll talk about Purpose 2. This is a study by Dr. Kelly and colleagues, and this is really a landmark study showing the efficacy of lenacapavir for pre-exposure prophylaxis to prevent HIV infection. And this is the landmark phase 3 double-blind, multi-center randomized control trial that took place in 92 sites across 7 countries and enrolled more than 3,200 cisgender sexual minority men, transgender women, transgender men, and non-binary people who have sex with people who are assigned male at birth. And in this case, you can see at the top, participants were randomized to receive either subcutaneous lenacapavir every 26 weeks, aka every 6 months, along with a once daily oral placebo that matched emtricitabine, tenofovir disoproxil fumarate, or FTDF. This is most commonly known as Truvada for folks who may have known that with PrEP. So this was a Truvada placebo, or they were randomized to take FTDF every day with a lenacapavir placebo injection subcutaneously every 26 weeks. And since FTDF is known to have efficacy as pre-exposure prophylaxis for HIV, the researchers here pursued a rather interesting strategy, which is that they compared incident HIV infections in the lenacapavir arm to the background incidence of HIV infection in the population. And so as you can see by the graph in the upper right here, lenacapavir was very effective. There were 0.1 infections per 100 person years compared to a background incidence of 2.37 infections per 100 person years. And then similarly, lenacapavir compared to the FTDF arm was also had lower infection prevalence or incidence in the lenacapavir arm. So this really showed a great efficacy and safety. We had similar discontinuation rates due to injection site reactions in both arms of this trial. And so this is now really one of the things that shot lenacapavir forward into FDA approval for now an injection every 6 months to prevent HIV infection. For the next study, This is a study by Dr. Last and colleagues that examined over 8,700 participants in the PRIDE study with diverse gender identities and conducted this analysis to look at the effects of anti-gender minority policies on the mental health of folks. So the policies that were looked at here were bathroom restrictions, youth bans in sports, and youth bans for gender affirming care, and looked at the effects of those statewide policies on anxiety, depression, and post-traumatic stress disorder symptoms. And so using a staggered difference in difference approach, the authors here found that compared to states that didn't enact any anti-gender minority policies, it's actually the SGM people who are living in states that enacted those policies that experienced both increases in their anxiety and PTSD symptoms approximately 1 year after the policies were enacted. There was no change in anxiety, depression, or PTSD symptoms among the gender minority people living in those states. And this was, I think, a little bit surprising to folks that there were anti-gender minority policies enacted in a state, but the effects were largely seen among the sexual minority people, the lesbian, the gay, the bisexual, the queer, not the gender minority people. And so this was really one of the studies that actually brings I think a larger call for collaboration and partnership amongst all under the LGBTQ plus umbrella. There's been some movements in various parts of the country to separate the trans and gender diverse people from the sexual minority people, and that those are two different fights to have. And what we're actually seeing here is that attacks against the gender minority people are affecting the mental health of sexual minority people, and is a larger effort to bring folks together. We did see high mental health symptoms, so high anxiety, depression, and PTSD scores among the gender minority folks in and out of the states that were enacting anti-gender minority policies. For the next study, this is a study by Dr. Masakian and colleagues who this is a retrospective analysis that looked at what dose of weekly injectable estradiol, whether that was estradiol valerate or estradiol cypionate, and either in a intramuscular or subcutaneous route, was needed to achieve the guideline-directed estradiol concentration. So both WPATH, the World Professional Association for Transgender Health, and the Endocrine Society both have guidelines about what estradiol concentration should be achieved for folks taking gender-affirming hormones. And so in this study of 562 patients across 6 different sites, there were only 131 of them that met the guideline-directed goal of having an estradiol concentration of 100 to 200 picograms per milliliter. And most, actually 329 of the people in the study, had supraphysiologic, higher than guideline-directed concentrations. So they had concentrations greater than 200 picograms per milliliter. And among the 131 participants that did meet the guideline-directed goal, the median estradiol dose was 4 milligrams, and the median concentration in their blood was 146 picograms per milliliter. And we saw here that the route of administration, whether intramuscular or subcutaneous, was not significant in achieving those guideline-directed goals to get the right concentration. And whether you had estradiol valerate or estradiol cypionate, the ester was also not significant. And so this study really added evidence about the efficacy of injectable estradiol, and at doses, lower doses that than what are typically prescribed commonly in our practice. And so what we're seeing is that there were low doses here, and so this may actually this may impact the prescribing patterns to avoid some of the complications that people fear in gender-affirming care, things like hyperestrogenism and how that can relate to, for example, blood clots or other adverse effects. Additionally, of the 131 patients who achieved the guideline-directed concentration of estradiol in their blood, they also achieved 106 of those 131 suppressed their testosterone to levels less than 50 nanograms per deciliter, and actually had a total testosterone concentration of 4 nanograms per deciliter. And so this really also emphasized the impact that ingestible estradiol has at suppressing testosterone, which is commonly a desire that we want in people who are taking feminizing, gender-affirming hormones. The next study relates to youth, and this is looking at the emotional health of gender-affirming hormone therapy in transgender youth ages between 12 and 20. This was a study done in 315 youth at 4 sites across the United States in Chicago, Boston, Los Angeles, and San Francisco. And these were youth who were starting their gender transition and were naive to gender-affirming hormone therapy. And so in this study, Dr. Olson, Kennedy, and colleagues collected several emotional health measures, as well as a measure of what's called appearance congruence. This is a self-reported measure about the alignment between one's gender identity and their external appearance to the world. And so these emotional health measures, as well as gender appearance congruence, were measured at baseline, and then every 6 months after starting gender-affirming hormone therapy, all the way out to 24 months. So at 0, 6, 12, 18, and 24 months. And here we saw that participants in this study demonstrated improved appearance congruence, along with improved psychological well-being, social satisfaction, and self-efficacy. And they had less negative social perceptions, aka improved social perceptions, and less negative affect, so an improved affect. And so this study provided yet another piece now of growing evidence that gender-affirming hormone therapy in transgender and gender diverse youth improves not only their self-perceptions, but also their emotional health. And the next study that I wanted to go over is a study by Dr. Street and colleagues. And this study looked at incident atherosclerotic cardiovascular disease among transgender and gender diverse veterans. So this was a study done in the VA health system. And this study used a validated natural language processing algorithm to identify the transgender veterans. So sexual orientation and gender identity, like in many electronic health records, is poorly collected. In the VA, that is oftentimes also the case. And so processing of the free text of clinical notes combined with other aspects in an algorithm helped to identify the over 42,000 transgender veterans that were identified here out of a cohort of greater than 1.1 million. And of those 42,000 transgender and gender diverse veterans, about 800 of them experienced incident atherosclerotic cardiovascular disease in the 9.4 years of follow-up in this study. And cardiovascular disease was really the key here, and looking at its association with gender-affirming hormone therapy. And so here, gender-affirming hormone therapy was actually associated with a reduced risk. You can see a reduced hazard ratio here of atherosclerotic cardiovascular disease in veterans who were assigned female at birth, and was not significantly associated with an increased hazard in atherosclerotic cardiovascular disease among veterans who were assigned male at birth. And so we would always think, if we take a look at this, folks who are assigned female at birth and starting gender-affirming hormones, this is typically masculinizing hormones. We often have this thought that testosterone-based therapies increase people's risk of cardiovascular disease. And again, we do not see an increased risk of incident atherosclerotic cardiovascular disease here. And for the people who are assigned male at birth and taking what would typically be associated as feminizing gender-affirming hormone therapy, that their risk was no different compared to vets not taking gender-affirming hormones at all in terms of incident cardiovascular disease. So this really, I think, aside from using this novel method to identify transgender and gender diverse people in an electronic health record system that doesn't have robust sexual orientation and gender identity data, this study also adds important evidence that can begin shifting the practice for clinicians so that they can really start to provide gender-affirming hormone therapy with maybe less fear that they may have about adverse cardiovascular disease risk. And I think this study helps make the case for policies that increase access to gender-affirming care is actually evidence-based health policy. So this was a whirlwind of 6 or so studies. There's many, many more, all of which I think are really important. And again, I will share those for you at the end. But I did want to spend another 10 minutes or so discussing the road ahead, which I feel looks a little bit like this, which is rather rough and bumpy and poorly paved. I think all of us have seen statements like these from the federal government that are trying to abolish who we are as people and also to discredit the work that we do. So our group, among many, and also many of the attendees here who I can see in the list, have received notices like the one on the bottom here from the NIH saying things like this award is terminated because it no longer effectuates agency priorities, that programs based on gender identity are not scientific, that they do nothing to enhance the health of Americans, and a whole bunch of other language that folks find pretty insulting. And so these statements have come out, and I think what also has come out is a bunch of statements from scientists about the impact of the current federal stance towards LGBT health research and health equity. And so we've seen ongoing commitments, including from our shop at the PRIDE study, but also many folks across the country, to keep and to have a variety of commitments. And these commitments include keeping the collected data safe and secure, that is out of the hands of any bad actors, while also continuing, really in spite of all of it, to continue to collect data, to continue to conduct analyses, and to continue to create scientific evidence going forward. And that, I think, we've really seen now, even with greater light, to be done by a variety of ongoing studies that have demonstrated and shown their commitment. So we're not expecting to have LGBT health data anymore from federal sources like we have in the past. So people may be familiar with the National Health and Nutrition Examination Survey, or NHANES, or the Behavioral Risk Factor Surveillance System, which sometimes gets called BRFSS or BRFS as it gets nicknamed. And so we're not really going to see sexual orientation and gender identity largely collected on federal health studies going forward, but the longitudinal data collection remains. And that remains in cohorts that are focused on people living with HIV. So that includes folks like the Max Wise cohort, which is the Max Wise combined cohort study, as well as Encore, which is working for transgender women living with HIV, and NA Accord is a very large North American consortium of HIV-related cohorts. We also have cohorts of LGBT people living with specific diagnoses like PRIDE-CF, which is an ongoing cohort study of LGBTQ plus people living with cystic fibrosis. We also have general LGBTQ plus cohorts like the STRONG cohort based out of Kaiser, and of course the PRIDE study here based out of Stanford. And then we also see some national cohort studies for all people that are actually rigorously collecting sexual orientation and gender identity from every single one of their participants. So the All of Us research program is truly an NIH-driven cohort study with a consortium of many sites across the country, including Stanford. And this is a program to collect, to have 1 million Americans participate in this study, and every single person is asked their sexual orientation and gender identity. So as this study completes its enrollment, it will undoubtedly be one of the largest sources of LGBTQ plus health related, of LGBTQ plus people participating in a research study going forward, combined with several other data types, including EHR data, surveys, biospecimen, and actually whole genome sequences from all 1 million people. So these things like this ongoing data collection keep me pretty excited and positive about the future, despite everything else that's going on. I also use when I get asked to give these talks, I get a little bit of my privilege here to stand up on a little bit of a soapbox, which is what I have up here. This is my soapbox to share what I want to see next, really in LGBTQ plus health. And I think, I describe for better or for worse the current state of LGBTQ health as we're still stuck in maybe the 70s now. I used to say the 50s and 60s, but I think we're maybe up into the 70s now, in that there are so many basic descriptors of LGBTQ health that I don't have. I cannot tell you the number of LGBT people in this country that have diabetes. I can't tell you the number of people that have heart disease. I can't tell you the number of people that have high blood pressure, or some of the most common things in the country. And that's because we don't collect sexual orientation and gender identity in the census, which means we don't collect it in any of these federally representative health studies that get done. And so I do think we do need these continued cross-sectional studies to uncover associations between people's various identities and their health outcomes, but also all the numerous social determinants of health that exist: where people live, their races and ethnicities, their incomes, their jobs, their safety of their environments, whether their support networks. All of these aspects all have undoubtedly important associations that can help us start to identify interventions. But at the same time as this, I also want to see causal inference studies going forward. We now have longitudinal data. I just showed you a slide with a whole bunch of longitudinal cohorts that are ongoing. There's more and more of these that have longitudinal data that have been and will continue to be collected, that I think we can start to think about having maybe more complex epidemiologic methods to start looking at the basis and the motivators behind some of these health outcomes. I'd also like to see us move away from the doom and gloom model that has permeated LGBT health research for a very long time, and has actually permeated, I think, the general public's view of LGBTQ plus people, that we're subject to all this discrimination and stigma and all these things, which is true, but there's also some resiliency as to why we are all still around, and ideally not only just surviving but thriving throughout some of these very challenging times. And then the other part, which has gradually grown in LGBT health, actually more than in a lot of other places, is having a community engaged approach to the research. So this is having community members hand in hand with the academic folks, with nonprofit organizations and others, that are co-designing and co-conducting every single research project. We want to make sure that the work that we're doing is work that the community wants us to do and needs us to do, and is not just something that Mitchell Lunn, as an associate professor at Stanford, thinks is interesting. We really want to make sure that the work we're doing is going to be out there to maximize the health and well-being of our communities. And so this is really, I think we need some different measures to measure our societal experiences in different ways. Also measuring our gender expression. All of us have a gender expression, whether you're cisgender, transgender, gender diverse, or otherwise. I am wearing, as I said, a button-down shirt today. I have facial hair. I have a rather masculine haircut. All of these things are things that I do to convey my gender expression, and all of us do this, but we don't really have great ways of measuring this in a self-reported way, for example. And then as technologies are continuing to advance, I mean, we have devices like this that I'm holding up here that can collect blood from people at home without a phlebotomist, that they can send back through the mail. We have now these various technologies that are advancing, where geographically distributed studies like the PRIDE study, but many others at Stanford as well, that are being conducted across the country and are not just local, now have the ability to collect different data types than were ever possible before. We never used to be able to easily collect blood by a participant collecting it themselves at their house and sending it back through the mail without having, a bunch of complex logistics. And so all these things are really opening up new avenues of biologic factors that we can start to look at that may be impacted by people's experiences in society or otherwise. And so I think the future is very exciting and interesting and is bound to be quite innovative. So I promised at the beginning that this, that this would have not have been possible without LGBT health researchers from across the country sending me impactful publications in their perspective over the past year. So the other 39 that I didn't present, as well as the 6 that I did, are all available in this this PDF. You're more than welcome to scan this QR code. Wei Chen, I'll send you the document after so that you can also distribute it maybe to the attendees directly. And feel free to send this wherever. This is just there were multiples. Many of these studies were provided to me by folks at least twice, if not more than that. So when I got it repeated papers from different people, it was really an interesting, it was really indicative that they were largely ones that people found memorable and impactful in the field. Before I wrap up and have some time for questions, I did want to close, and I think I want to reflect a little bit on science right now. And so I think everybody here knows that science is the pursuit of truth, and science in LGBT health world really drives health and health equity forward. Science helps uncover many of our health disparities that we have. It also informs policies, regulations, and laws. I read, for better or for worse, Supreme Court and other court briefings all the time and see work from folks at Stanford, from folks at the PRIDE study, from folks all across the country having their work cited in briefs that lawyers are filing in pertinent court cases, whether that's the briefs themselves or friends of the court, the amicus briefs that happen by a variety of organizations. And so we know that science actually impacts judicial processes and impacts the health and rights of our communities. And of course, we all know that it fosters competent and inclusive healthcare systems that we're all a part of. And so my plea to all the scientists who are here listening, to all the trainees who are doing research or want to be researchers, and to all the providers and all the advocates, which is every single person here who partners with researchers in various ways, my plea really is this, which is to continue doing science. This is going to be hard, I think. It's already been hard since since March, effectively, when we saw a bunch of things going on. But I think our government is going to stand in the way, and we need to continue doing science. Our institutions, not necessarily Stanford, but other institutions across the country, are going to make things difficult. And so to do this kind of work, and so please continue to do science, whatever you can. And our colleagues, even our colleagues with well-meaning intentions, are going to suggest that we pivot to do something else and move away from LGBT health work or do something else. And my plea here again would be to continue doing the science that you love and that you feel is important. And again, please, please, please continue doing science and not let the others win, I guess, and push us away. And I really think that's because really our communities depend on all of this. So I want to thank all the researchers that were involved in all of these studies and many others, all the research participants, which none of this work is possible without research participants participating in studies. And thank you all for being here and chatting today. And I'm happy to take questions, and people can either come off of mute or type them in the chat, and we can have a little bit discussion about either some of the cutting edge science that's been happening over the past year or just the current environment at Stanford and nationally. Thank you so much.
Thank you so much, Dr. Lunn. And I hope you saw all the hearts and claps that were coming up on the
Saw a couple,
screen.
yes, yeah, thank you.
Good, well deserved. And I am personally reflecting so much on learning about how recent studies have really clarified misconceptions around health risks of gender-affirming hormone therapy. And the clear lines are really evident through how these studies inform future policy developments. So, of course, hoping to see some of this impact legislation coming forward. One question, oh, before I do that, before I jump into questions, just want to remind folks that this session is being recorded and will be uploaded to the Department of OBGYN's public YouTube page. So you're more than welcome, as Dr. Lunn said, to come on the mic and ask questions, or if you'd like, you can drop your question in the chat and we can read them aloud for you without associating your name with that. So please feel free to do that. And while you may be typing or thinking, I want to pose this question to you, Dr. Lunn. We've seen mental health and psychological impacts of the anti-LGBTQ plus legislation on the community, and I'm curious to see if we have noticed any impacts on physical health broadly across the nation at this point, and what that's kind of looking like right now.
Yeah, I don't think we know that for sure. I mean, we know a little bit. We're seeing, so the first paper that I presented, for example, on sexual orientation and gender identity change efforts, those are typically done either by religious organizations or mental health providers. To be clear, conversion therapy, I put in giant quotes because it is largely shown to be nothing but harmful to folks at all ages, and there was just a Supreme Court case a couple of weeks ago discussing that to overturn that ban in the spirit of religious freedom. It is currently, conversion therapy for minors is outlawed in I forget the exact number of states, maybe 27 or so right now, and has varying degrees in other places. And so we're seeing the effects of things like that have impacts on people's physical health in addition to mental health. And then I think we do know there is data that folks broadly, and these are great spaces for interventional studies, have, that the LGBT population as a whole has increased, for example, substance use compared to the non-LGBT population. And that's largely believed to be, as maybe unhealthy coping mechanisms to the stigma discrimination that they get from society, right? So increased amounts of smoking, increased amounts of vaping, increased cannabis use, increased illegal drug use, increased alcohol use. All of those things I think are all there. And again, important to know and important to have there. But also, I think we need to start thinking about the why. Why is that happening? What is the root cause of some of that? And then thinking about, are there interventional studies that we can design to either intervene at the why, at the stigma and discrimination standpoint, or if we can't do it there, can we provide, say, more healthy coping mechanisms rather than substance use that people can turn to, can arm people with those tools rather than reaching for a cigarette to handle some of the stress in their lives. But they are definitely reasonable things. As an aside, if I can can add a little bit more, we are seeing I think what we think is a relatively new trend, and we have a paper coming up about this hopefully soon, is the trend now that we're starting to see is more people are thinking about leaving the states that they're in, so moving as a solution to some of the stigma and discrimination. That has not largely, that's always been the case where people have moved from states that may have more negative policies to states that have more welcoming policies and more positive policies and laws and regulations, but not always. And now I think with this, we now, as of the middle of September, have more than 600 anti-LGBTQ plus bills that are percolating through state legislatures in every state except for Vermont and the District of Columbia. And so those are, people are, never at a time in ever before has LGBT people been under as much attack as they are now. And so people now have a very heightened sense of what laws and regulations are being passed in their state, and people are either actively considering moving, and many folks have made plans to move, and many folks have actually already moved. And so, of course, that is a privileged position. Not everybody can just get up and move to another state. Is a very complex thing, but we are seeing people doing that more, I think, than we ever have before. And so that, may be a healthy way of coping with some things that are happening, but again, one that requires substantial resources and privilege in order to do that.
Yes, absolutely. It sounds like current circumstances are exacerbating a lot of the existing health disparities that we already saw in our communities,
Right.
and that we can really take care to hold each other and hold the space, these types of spaces, as an effort and to intervene and to provide these sort of collective care opportunities.
Yeah, and I think, we do see that folks who have multiple risk factors for, say, things like suicidality oftentimes also score lower on some kind of standardized instruments for kind of global health as a whole. That also has a physical health and a mental health subscore. So of course, we would think that the folks who are having lots of suicidal thoughts or severe depression or other things like that may have worse mental health scores. We also commonly see that they have worse physical health scores as well. And I think that that's probably not surprising to lots of us. We've all had periods where we've maybe felt down in our lives, and those are times where we probably take less good care of ourselves physically also, right? You're either not sleeping, you're sleeping too much, you're not exercising, you're eating poorly, all these sorts of things that can happen. For many of us, that happens just on periodic episodic things that are that we manage and are part of being a normal adult human being. But for others, where it lasts, where it's enduring, I think it can be really detrimental in terms of both physical and mental health. So we are really seeing those across the way. And this really gets to some of the things that I alluded to a little bit, that these important cross-sectional studies are important because they start establishing these associations, where association with an outcome here has this associated outcome elsewhere. And a little bit, sometimes it's a little bit of water is wet research. Like, we're proving that people who are stigmatized and discriminated against have worse mental health. You're like, surprise! It's really not a surprise to very many people. But I think, if we don't do that, we oftentimes get from the naysayers in the world, well, where's the evidence that that's actually happening, and that sort of thing. So, and I guess this is, harkening back to the conversion practices example, we oftentimes, the field, the folks who are advocating to allow conversion practices to continue often say, well, there's never been a study showing that conversion practices are harmful. And in a way, that's true, because it would force us to randomize young people to get conversion practices or not, which is an unethical thing to do in the first place. Like, there's never going to be a randomized trial of whether or not somebody goes towards sexual orientation and gender identity change efforts or not. And so that's always going to be a perspective of folks that the data is not the kind of top tier level of evidence of a randomized trial proving something for certain things. And the example that I give is that, yeah, you don't have to prove that for everything. Like, there was never a randomized trial to prove if parachutes work, right? Where two people jumped out of a plane, one person with a parachute and one person didn't. Like, that was obvious, right? So that's kind of the example that is oftentimes given in RCTs, and that an RCT is not always the best or the most ethical approach for lots of research.
Absolutely. And I think that also speaks to the way that a lot of times qualitative data and narrative data is undervalued, like the extreme focus on quantitative data. We need the numbers for this. We need the significance tests, rather than simply listening to folks and like using that data to see, gosh, everyone is saying this. That could really be a way that we can uplift and continue to uplift voices from the community moving forward in this time as well.
Yeah, and I think that's a key point. Thanks for bringing it. It's like I planted that with you, Wade. I didn't even ask you to do that. No, because I think what we're seeing now is we're seeing just generally in society, we're seeing folks who have always been LGBTQ plus health supporters. We have other folks who are somewhere in the middle, and for another set of folks, numbers and the quantitative things are actually not winning over hearts and minds. And so we're actually needing the narrative stories of individual people and their experience with a variety of things and getting those stories out. We're now seeing larger numbers of folks on Instagram and Blue Sky and TikTok and others producing really short videos about their experiences in healthcare, about their experiences in research, about their experiences of just being a trans person walking through the world and what things they experience that are good and things that they experience that are bad. And those individual stories are oftentimes very helpful in starting to, add a little bit of insight into what it's like to walk in another person's shoes, that an adjusted odds ratio doesn't necessarily give you, the feels, the emotions that go along with that.
Absolutely. And this is absolutely an intentional layup for you. But for folks
Okay.
who may want to participate in research and inform these developments and this policy work, these broader narratives, how can they get involved?
Yeah, I think there's a variety of ways to get involved. So one is to contact us at the Pride Study. You can contact me. I'll put my email in here. It's just my last name. It's pretty easy. There's a variety of ways that we have more data than we will ever be able to analyze in my lifetime. And we're continuing to collect data. So part of this is we're always interested in folks who are willing to collaborate with us to take some of that data and answer a research question that may be of interest to you. We have our annual questionnaire that we have people complete takes an hour to an hour and 15 minutes. It is deep. It is in depth. It is long and asks a lot of questions, some of which are very personal and very sensitive, and others are less so. And so we're always looking for trainees, for early career faculty, for postdocs, for staff, for anybody who really wants to partner with us to work on some of these projects collectively. Again, on topics that you may be interested in. So I think that's one. If you're an LGBTQ plus person, feel free to join and participate in the Pride Study. You can subscribe to the LGBTQ plus health programs newsletter, see the QR code on Wei Chen's background. And if you're faculty, there's a faculty mixer on Thursday. Thursday, is that right? Thursday. Okay, on Thursday, to start, having a little bit more collaborations and work between faculty members, both socially but also professionally. So. I think all of those are ways to get involved. There's now, and I would also argue that even if you're not an LGBTQ plus health researcher, but you do any kind of research, I would encourage you to ask your research participants their sexual orientation and gender identity. If you need help figuring out how to ask those questions, please email me. There's lots of great ways to do it. And this is really because the largest issue is lack of visibility of people's sexual orientation and gender identity in research studies. So you can guarantee that pick up JAMA, pick up the New England Journal of Medicine, pick up any journal, and I can guarantee you that there are LGBTQ plus people that participated in every single one of those studies. But we're invisible because sexual orientation and gender identity is rarely collected. And so it needs to be in every single study that we do so that we can start, that helps contribute to the evidence base, right? Because we can then start to combine data sets and other things if we know where LGBT people actually are.
Absolutely. And it reminds me of a statement that we like to fall back on in the program is if you don't think you take care of LGBTQ plus folks, you do.
Right.
You definitely
Yes,
do. And it's
exactly.
just a matter of orienting to that mindset, that mind frame, and also recognizing, particularly in the Bay Area, we're looking at like 25% of us.
Yeah, easily, right? Yeah, I mean, we have data now, since it's not collected on the US Census, we don't know for sure. Gallup does random digit dialing every day. We say 9.3% of the adult population is identifying as LGBTQ plus, so 18 or older. This is folks answering affirmatively to a random stranger, calling them on the phone and asking them if they're gay. So it's clearly probably a floor that the number is actually higher than that. And then for folks who are the youngest vintage, the Generation Zers, the 18 to 24, 25-year-olds right now, about 1 in 4 of them are identifying as LGBT to a Gallup poll. So I think we're seeing society change. I'm curious to see if that number will actually decrease next year as society has become a little harder this past year. And so we'll see what happens. But we do know that a single affirming adult in a LGBTQ plus youth's life has profound impacts on their mental health and suicidality. And so that's one thing that all of us can do, is to just be welcoming and affirming and not be judgmental to people. And that has like a huge, giant effect on folks. And so I would encourage everybody to think of ways that they can be just in your daily lives, be nice people towards LGBT folks.
Absolutely. And for folks who'd like to stay up to date on this research, I know we have the list of 45 publications. That is a great starting point. But are there specific journals, specific centers, teams, cohorts that folks should look to for new publications?
Yeah, that's a great question. So there's I think the biggest kind of LGBT health journals are the journal called LGBT Health. There's a journal called Transgender Health as well. There's a journal, the International Journal of Transgender Health as well, and several others. I think we're also starting to see there are groups across the country. There's a group called the Impact Group, which is based out of Northwestern in Chicago. They do a lot of great work. Fenway Health in Boston has the Fenway Institute, which produces some research. Our group obviously does research, and there's many other groups, including the Williams Institute that does more law and health and policy and demographic work, based out of UCLA, and several others. I think the way to do, and we're also thankfully, happily, I think now is seeing LGBTQ plus health related work appear in not LGBTQ health focused journals. So we're now seeing, the New England Journal of Medicine publish LGBT health work. Oh, thanks, Anne. Yeah, that's now called Impact. They had to rebrand themselves. They got rid of SGM in their title, so it is now actually called Impact. That's exactly the group from Northwestern, Brian Mustanci's group that I was mentioning. So yeah, so I'm glad that we're seeing LGBT health stuff published in New England Journal and JAMA Network Open and some of the JAMA subjournals and all of the, and Lancet, so really the whole Nature series is published stuff is now really, I think, continually growing, as sources. I think the easiest way to do this, to follow things, is to actually set PubMed publication alerts on your particular topic with some assorted LGBTQIA plus terms that you can put into a giant search term if you want, separated by ORs. And so those, I think, are some of the ways to track a lot of the work. And then our newsletter at the Pride Study, which you can sign up just by visiting our website. On the upper top part, there's a thing that says Get Updates, and you can sign up for our newsletter that way. You'll hear about our work the second it is published. We notify all of our participants on all of our newsletter folks before we notify anybody else. So they're the first group that we have. And then we publish, in addition to getting the paper, we also publish a lay language summary of that. So it's without kind of the technical, statistical, or otherwise jargon that can sometimes make some of these papers inaccessible.
Thank you so much for sharing that.
Sure.
And I know in these last few minutes, folks are curious about, with the resourcing challenges for LGBTQ plus research, particularly this year, how folks can continue to support you and your ongoing work, how they can continue to support the Pride Study, What can we do for you, Dr. Lunn?
Yeah, great question. So I think you can follow us on social media. We're on, X, Instagram, Facebook. We're probably moving to Blue Sky and TikTok, if you can believe it. Coming soon to a channel near you. And so if folks can follow those, folks can retweet and repost and engage with those in various ways. Because I think as you post it to your, repost it to your networks, it gets larger spread. I would share the Pride study and other folks with your LGBTQ plus friends and family, and of course yourself if you're able to, if you'd like to join. The other thing is if people have unique expertise that you would like to volunteer for us, we could always use that. Sometimes it's like, I'm really good at graphic design, I can do a little flyer for you, or these sorts of things. So really, we have a need for almost every skill, I think, that people have. And so that's one way. Folks can also donate to us, pride.stanford.edu, and a few other, I think, source ways. Time, you can send trainees to us, you can collaborate with us. There's really a whole, I think, variety of ways that we can help, collaborate / you can help us in a variety of different ways.
Excellent. And I'm so glad that the Pride Study continues to exist, that we can
Yeah.
continue to support you in many ways and continue to grow our networks to make sure that the Pride Study continues to
Yeah,
exist.
we're not going anywhere. We made that very clear. And both, the Pred study, because Juno and I, Juno Obed and Maliver and OBGYN and I were the two co-founders and two of the now three co-directors. I'm in the Department of Medicine as a nephrologist, Juno's in OBGYN, and both the support that both of our departments have given, I think, as well, to keep this program up and running and to continue, again, our three goals: keep and safeguard the data that we have, continue to collect new data, continue to do science, are things that we're going to be able to continue doing, even with these the kind of rough times that we're in right now. Our community, the LGBT community, has had many rough times over its history. For folks who are old enough, the beginnings of the HIV epidemic in the late 80s and 90s is definitely one of them that many people, if you weren't around during it, you at least have heard about it. Is one that we have weathered, right? And we now have medication that is a twice a year injectable medication to prevent HIV, right? That was never thought about in 1990, right? So I think there's lots of advances that have happened, and these are all things that I think will help us continue to thrive. So thank you.
They certainly will. And on that note of hope and optimism, we thank everyone for joining LGBTQ plus Health Grand Rounds. Thank you again to Dr. Mitchell R. Lunn for a great presentation. I hope you're seeing all the emojis pop up on the screen
I
for
sure
you
am.
now. Thank you all for being here and being in community with us. Take good care, and we'll see you next month. Bye,
Thanks, everyone.
everyone.
Bye-bye.